I'm Rita Redberg. I'm a cardiologist at the University of California, San Francisco, and I'm editor-in-chief of JAMA Internal Medicine. So I became editor of JAMA Internal Medicine in 2009. And shortly after that, I was talking with one of my colleagues and deputy editor, Deborah Grady, because the U.S. Preventive Services Task Force had just issued new recommendations that women between the ages of 40 and 50 should have a conversation and not just get a mammogram because the harms would outweigh the benefits for women in that age group. And you may remember, I don't know if Luca will, but that was not very well received. And in fact, the task force was very harshly criticized for wanting to ration care and, for not caring about women and all kinds of things that really Deborah and I could not understand why it was so poorly received, because it was a very thoughtful, evidence-based recommendation. And we thought that people probably hadn't heard that message, that actually having mammography would be more likely to be harmful in that age group. And then we thought about, there are a lot of things that if they have no benefit, like mammography in that age group, then all you're left with is the harms, because there's really nothing we can do, even simple tests that don't have some risk or some harms, potential harms. And that is how we decided to launch the Less is More section of the JAMA Internal Medicine, because we wanted to have a journal that could tell that story, because while certainly we do lots of great things for our patients, we also do things that harm our patients. And I think, of course, unintentionally, and not really being aware that this was harmful and that nobody was talking about it. And the only way to start that conversation, we thought, was to start publishing articles. And so that's how we launched the Less is More series. I do think young internists are the key, and that is exactly, Nick, why we launched Teachable Moments, because we wanted to hear from young internists. We wanted to engage in conversations, and we wanted to hear their stories. And so Teachable Moments are stories from a trainee. The first author must be a trainee, where in your training you observe something that perhaps seemed like a good idea at the time, but turned out not to be so good for the patient. And it's very likely that other people have had that same experience or might have that same experience. And so the idea of Teachable Moments is that trainees can share their stories and in a constructive way. So tell what happened with the patient, and then what is the evidence in this area? What do we know about harms and benefits? And then how could we do better for the future? And we have gotten some amazing stories from trainees all over the world. And as you said, I think, trainees are our future. And this is really how medicine will be shaped, going forward. And we think it's so important to hear from trainees and publish their stories. So, yes, I do. I think that there is certainly more awareness of overdiagnosis and overtreatment, but I'm not sure that we've sort of stemmed the tide, because I think most forces in medicine kind of push us towards overdiagnosis and overtreatment. There are a lot of things, and actually Deborah and I wrote about them in that first editorial when we launched Less is More. But we like to do something. We think it's sometimes hard for physicians to say, no, we don't think we need to do anything. We don't need any test, any treatment. And just to reassure the patient that that will be the best course, And while actually I think patients are very happy to hear from their doctor that they don't need anything, part of our culture of medicine is feeling like we have to do something, and something like ordering a test or a treatment. And so I think, sort of thinking more about doing something could be just talking to your patient and reassuring them is an important way to overcome overdiagnosis. We have lots of new technologies. People are fascinated with new technologies and tend to sort of think a technology will be better without really looking at the evidence for its benefits and harms. And then, of course, we have fee-for-service in a lot of countries, certainly the US, where you're paid to do more. And so there are a lot of reasons that, even though there has been certainly a much more robust international discussion on choosing wisely and overdiagnosis, I think it's still a very large problem. For example, just yesterday in the JAMA Internal Medicine, we published an article from the Danish lung cancer screening trial suggested for lung cancer screening, which was approved in 2014 from Medicare and from the U.S. Preventive Services Task Force. The overdiagnosis rate for lung cancer was 67%. They are just staggering numbers. And conflict of interest is definitely an important factor. I mean, not for everyone, but there is a lot of industry relationships. And I think it's not just on the individual level, but in the professional societies. So, we have guidelines from professional societies about, what we should and shouldn't do. And the professional societies get a lot of their funding from industry.
Sure.
And the professional societies, have standards on conflict of interest for the guidelines. But we've published, multiple articles over the last 10 years showing that professional societies don't even follow their own conflict of interest guidelines. And so frequently these guidelines are chaired by people who have a conflict. And I think that means, particularly in areas, which is true for a lot of areas where there aren't high quality randomized controlled trials, you're relying a lot on expert opinion for these guidelines. And when there is financial conflict, I don't think you're getting an objective opinion. So, a good question. I think I would start with advice I got when I was a medical student that I think really did influence how I started thinking about medicine and taking care of patients. And it was advice I got from John Eisenberg, who was my mentor at that time and chief of the general internal medicine at University of Pennsylvania. But he said, and it's even more true today, there are lots of tests that we can order and we'll get information. But the point of ordering a test isn't to get information as an end. The point is, will that information help the patient, help me to manage that patient in a way that I couldn't have done without the information, and will they be better off as a result of the way I'm going to use that information? And so I think that's really important to think about that before ordering a test, because reflexively, it's very easy to order tests. But it's a lot harder to order a test if you have to answer the question, okay, how is this information going to help me take care of the patient in a way I couldn't have done without that test? And so I think that's sort of my first rule for choosing wisely. And then the second is related to what I mentioned earlier, to remember that, think about, why did the patient come to see you? Because patients come, I think, a lot of times because they want reassurance, not because they necessarily want a test. And I think we think patients want a test. When we did some focus groups on why do we order unnecessary, in this case it was cardiac catheterizations, and a lot of doctors told us, well, patients expect it. But I think patients expect what we've conditioned them to expect, and I think patients really appreciate reassurance. Doctors are very respected professionals. You reassure your patient, they they didn't come wanting a test. They really came wanting to know that whatever they're worried about is not some terrible disease, or that if it is, you're going to do, help them through it. And then the third is, sort of related to that, is that sometimes it's better not to do something than it is to do something, and to really think about harms and benefits and explain those to patients, so that we can do what is going to help them, but not see our role as just ordering a test or a treatment.